Thank you, Dr. Subudhi, sir. Well, I'm speaking in a hall full of great cataract surgeons. So, this is just a small talk on the astigmatism management in manual small incision cataract surgery. Well, all of us Indian ophthalmologists are very, very good in doing cataract surgery, and I would say perhaps the best in the world, second to none. Not just India, all South Asian ophthalmologists. And over the last few decades, phacoemulsification has become a surgery of choice for almost all of us in private practice settings and in many institutes. And many people consider it exclusively as perhaps the best kind of cataract surgery that can be done. But then managing astigmatism can also be done in small incision cataract surgery, and we can get equally good results with that. If you can set the timer, it is giving a different one. Well, we all know astigmatism can be a limiting factor in patient satisfaction. We surgeons are happy with best corrected visual acuity, but today patients consider the success of surgery on unaided visual acuity. So the correct IOL power takes care of the sphere, but then we have to take care of the cylinder. When I did my residency in 1990s, this was the most common refraction that we gave. Well, when we started IOLs in 95, the sphere went away. When the phaco SICS started, the cylinder went away. And now with multifocal implants, even the near addition is going away. And when patient goes, they don't want to wear any kind of spectacles. So we all know that when we compare the astigmatism between SICS and phaco, and we have numerous randomized controlled trials to that, the average astigmatism in SICS is about 0.7 to 1, and the astigmatism in phaco is about half a diopter, because obviously the incision is lesser in phaco. So this is what we had published in JCRS, the second large RCT that we had done. There is of course a difference both at 1 week and at 6 weeks. In fact, we also did a meta-analysis comparing 7 head-to-head comparisons between SICS and phaco, and the only differentiating factor is the astigmatism. The dot line that you see is what is the final result, the one in the center, and this, if you will see this quadrilateral, this is completely on one side. So that means that in all the studies, the astigmatism is lesser in phaco for sure. But then it's not just distant vision. If we look at near vision, then in manual small incision cataract surgery, patients get better unaided near vision. Now we all have seen our phaco patients. We are very happy because the next day they are able to read 6/9. But patient says, doctor, earlier I could see the mobile, earlier I could read my newspaper, now I can't read the newspaper. So we tell them, you can see far so well, but it's not just far, they also need near things, where the astigmatism of SICS helps. So, well, we can use the astigmatism in phaco by doing temporal incisions, incisions on steeper meridians, using LRIs and now toric IOLs. But all of that can be done in SICS too, because scleral tunnel incisions that way are very kind in nature. They are secure, they heal well, they are forgiving. So how can we minimize astigmatism in SICS? One is, of course, we take the astigmatic consideration, the frown incision, which gives best wound stability, gives the least amount of astigmatism. We have the concept of the astigmatically neutral funnel. So if we are doing large black brown cataracts, which a lot of us do, we just have to go more posteriorly. Well, we can use the chevron, we can use the frown, but we also have to understand that in manual SICS, there is a trade-off between lesser astigmatism and corneal clarity. People do 2 mm, 3 mm, 4 mm SICS also, and in expert hands, it works well. But the more we play around in the anterior chamber, more are the chances of endothelial cell loss, and this is something that we can get. And referring cataract patients to corneal colleagues is not the best thing for our practice. So for site of incision, temporal or superior temporal is better. So time to hai aur in fact, there are now more recent advances. There is Smart SICS by Dr. Rajiv Raut, or there is the Ranjan's marker, or Dr. Sudhir Singh has his own technique, or Dr. Sahu has 3 mm, 2 mm SICS. And And they hope to give not just 6-9 unaided for distance, but N6 or unaided for near. And what is the reason for that? The reason is, like it is in this ad, in which kuch daag achhe hote hain. In it, astigmatism actually gives better unaided near vision. So we all think of astigmatism as a curse, but we can use the astigmatism well to get unaided distance and near vision. It may not be 6-6 N6, but a lot of patients are happy with 6-9, 6-12 and N8 or N10, because even with multifocals, that is what we promise them, 6-9 N8. So if this is the straight incision, if you keep on going behind, these are Dr. Boramani's slides, the astigmatism, as you can see, keeps on reducing. So in superior straight incision, if this is the astigmatism, in a curved incision, it is lesser. We've done a large study on temporal SICS, 2000 patients in Nashik, and manual SICS temporally is also found to be as safe, and the entire Arvind Eye Care system does temporal SICS. Similarly, we can have temporal straight incisions, we can have temporal curved incisions, and all of them reduce SIA. Always you take incision on the steeper meridian, so since we have the nose in between, we get 180 degrees for the left eye, 180 degrees for the right eye to be able to do that. And if you look at corneal topography, I'll just rush through these slides. Suppose you have a high astigmatism like that, 3.5 diopters. Normally we would have put a toric lens. But if we take a larger incision, then because the surgically induced astigmatism is more, we don't need a toric lens, and we can have a patient who's 6-9 N8. So we can even put a multifocal. So instead of doing a multifocal toric with a phaco, we can do a multifocal toric with SICS. So, and of course it's going to save the patient money. We will earn more money when we do that. So like a superior nasal incision, if it is done, we get almost 6-9 vision. Even the near vision is very, very good. So instead of calling it surgically induced astigmatism, let's call it surgically corrected astigmatism. And it's many a times a customized incision cataract surgery. So we do a lot of patients, a lot of our poor patients are patients who cannot pay that well. We are doing SICS. If we really just plan a bit, give it time, we will be able to give better unaided distance and near vision to these patients. And patients will be happy, and well, happy patients are what shall we say, our best advertisers. And there is so much that can be done with manual SICS. And there are kinds of cataract, brown, black cataract, subluxated lenses, decompensated corneas, where SICS is definitely better than phaco. So thank you once more for giving me this opportunity and hearing me out. Thank you.
Thank you, Dr. Parikshit, for the nice